Thank you for watching the World Community Magazine's Hour of Power Live on Facebook with your host Edward McQueen and April Garner.
Hello, hello, hello. Good evening, everyone, and welcome to the World Community Magazine. I'm April Garner, of course, the co-host. The host is on the sidelines tonight, just watching, but he's not too far away. He's making sure that we get it right tonight, right, Sister Joella?
Yes, ma'am.
All right. And of course, the lovely Sister Joella is the co-host for the evening. How are you, Sister Joella?
I'm blessed and highly favored, and I just thank you for just taking this and doing exactly what I know that you're able to do. Okay.
All right. Well, I appreciate that. And of course, we welcome all of you. Thank you for joining us this evening. We have a wonderful show lined up for you, and an even more special guest who's going to be speaking with us tonight about breast care and the importance of screenings. And so joining us today is Dr. Regina Hampton. And I have a bio for her. And let me tell you, it's pretty extensive. It would probably take up half of our show. And I told her I'm just going to touch on some of the highlights, and then I'll let her do the talking, because, we're all about, having a conversation and learning things here. But, Dr. Hampton, she is something special. I tell you, she's a medical doctor of the Breast Cancer or the Breast Care Center of Doctors Community Medical Center, and the first breast center in Prince George's County. So she's not a local, she's actually in the Maryland, DC area. And Dr. Hampton is also a co-founder of Breast Care for Washington. She's a co-founder of Cherry Blossom Intimates, and she's been featured in Washington Post regarding Black women and breast cancer. She's been featured in Essence Magazine, appeared on NPR, The Russ Parr Show, Buddy Check 9, recognized as a top doctor in the Washingtonian Magazine. So many wonderful things. And yet the most important endeavor of her life is making sure that women have a fighting chance when it comes down to fighting breast cancer. So welcome tonight, Dr. Regina Hampton. How are you?
I'm doing great. Thank you so much for having me. And hello.
Yes, very welcome. Thank you so much. And of course, Sister Joella reached out and wanted to pull together this show because of it is March, and it's Women's Month, and we wanted to make sure that we focus on women and bring in a very special topic to the forefront. So if you will, Dr. Hampton, will you tell us a little bit more about yourself, especially what inspired you to go into medicine and also to do this important work?
So I think it's funny, I always thought I wanted to be a doctor. I certainly never expected to be a surgeon. I thought I would do pediatrics or family practice, but when I did those rotations in school, I didn't like those. And I thought, oh God, what am I going to do? And then we call it got bit by the surgery bug, and just realized I loved working with my hands and just loved the feeling being in the operating room. And then when I got into practice, I was one of the few female surgeons in my area. And so people just started sending me all the breast cases. And so then I changed my practice into a breast-only practice. And just it really came out of, there are a lot of African-American women in the area where I practice. And I really got tired of the men, not that there are bad male surgeons, because there's some great male surgeons and great male physicians, but I just felt like for the women in my community, they weren't really taking the time to present them all the options, to really understand some of the unique challenges that they have. And so I feel like because I look like them, I really can get them and understand them and really speak to them in a way that probably few other people are able to do. So I just love it. And sort of out of that is kind of where everything else bloomed, from Breast Care for Washington and Cherry Blossom Intimates, all just with the same mission of really focusing on the needs of women of color in breast cancer.
Well, I think it's wonderful that you have the energy to do all of this. I mean, aside from your medical work, you're also co-founding these organizations and doing that important work. And as we know, breast health, breast care, these are some of the things that we tend to overlook. We go about our days and We go to doctor's appointments for other things, and it's not until we have a slight scare or whatever that we stop long enough to really find out what's going on with that part of our anatomy. And as women, we especially need to understand how important it is to make that a part of self-care. So, one of the things that, of course, we're going to be discussing tonight is the importance of screenings. And then from there, we'll also talk about the process of post-surgery care should you have a procedure related to breast cancer or, any other type of breast health issue. We're also going to talk a little bit about bra fittings and bra types and for post-surgical care. And then Cherry Blossom Intimates, that is an intimate apparel line for women who've had breast procedures. So we have a lot to cover tonight. And Sister Joella, you can chime in at any time you want. We're just kind of setting up the show. And as a matter of fact, we'll let Dr. Hampton get into her presentation in just a moment. But I want to remind everyone that if you have any comments or questions, please post them in the thread, and we'll be sure to show them on screen and ask Dr. Hampton to chime in on your questions, comments, or even concerns that you may have. So, from there, where would you like to go, Dr. Hampton, as far as introducing more about this topic?
So I can dive right into the presentation. I think it'll definitely cover a lot of the topics. And then after that, we'll open it up for discussion and chat.
Sounds good. All right.
So what I'll do is I will share my screen. Let's see. All right. And okay.
There you go.
All righty. So
right.
Let's just dive right in. I always like to start these presentations with good news because, when I think about breast health, when I think about breast cancer, there certainly is a lot of good news. So what's some of the good news? So the good news is the 5-year survival rates for breast cancer have improved greatly over the years. So for a stage 0 or a stage 1, that's a very early breast cancer, the 5-year survival rates are about 100%. No one should die of a very early stage breast cancer. And even when we get to stage 2, the rates are in the 90% range. Stage 3 and 4 are steadily increasing. And what's interesting is people think, well, stage 4, it's gloom and doom, it's the end of the world. But, with our treatments, we're able to keep stage 4 patients alive and really turn it into a chronic disease for many women. So I know many women who live very fruitful, busy lives as stage 4 breast cancer survivors. The other good news is it's less diagnostic tests. So our surgeries are better. We're actually having to do less surgeries just to make a diagnosis. And that's because there's so many newer technologies, and we're going to talk about some of those. And for me as a surgeon, the real good news is that the outcomes are better cosmetically. We really can make a breast look like a breast. We can hide the scars. And that really makes women happy as they move on in survivorship and get past their initial cancer diagnosis and go on to live long lives. But let's talk about some disparities because there are some. So this paper came out and they looked at 25 cities in the United States. And what this study showed is that 5 Black women died needlessly every day from breast cancer. I always have to repeat that because I don't think everybody hears me. 5 Black women died needlessly, meaning they should not have died from breast cancer. And then let's dive a little deeper because African-American women are the least likely of all racial and ethnic groups in the US to survive 5 years after being diagnosed with breast cancer. Now, we just talked about good news for a stage 0 and a stage 1 breast cancer, and that is survivable. But for African-American women, the disparities are real and they exist. And so I always hope with my education that we can turn these numbers around so that we survive. So let's look even more at the disparity. So when we look at Black women versus white women, we actually get breast cancer less. So the incidence rate is about 12% lower, meaning we get less breast cancer. However, we die at a higher rate. And so you don't have to be in elementary school on virtual learning to know those numbers just don't add up. If we get less breast cancer, we really should be dying less. And when we look at how the mortality or the death rates have decreased over time, they've decreased greatly over the last couple of decades. It's decreased more, unfortunately, for white women, and yay for white women, because it's decreased by about 34% for white women, but only about 2% for Black women. And there's some challenges and some reasons why that is. So one of the challenges is that we as African-American women, we tend to be diagnosed with breast cancer at younger ages when compared to our white counterparts. So if you look at the numbers here, about 33% of all breast cancers in Black women are under the age of 50. Typically in the white women, it tends to be over the age of 60. And when women are diagnosed with younger breast cancer, it does come with some challenge. And it usually comes with a very unique type of cancer called triple negative. And that is a cancer that is not hormonally active and usually has to be treated with chemotherapy. But with some of our newer regimens, we're able to really get in early, get those triple negative patients treated early so that we can turn them into survivors.
Dr. Hampton, I wanted to ask you about that statistic. Yes, the 33% less than age 50. What are some contributing factors to that? Is it just because younger women are not really getting screened, or what is that number all about?
So it's a couple of factors. One, we think there's some genetic factors. And we think there are genetic factors that aren't picked up by the typical breast cancer gene, like the BRCA gene that we hear so prominently about. We think that there are some other genes in Black women and actually African women. Their cancers mirror our cancers. They tend to get younger breast cancer patients as well and tend to be triple negative. So we definitely need more research into that. The other thing is a typical young woman under the age of 40, she's not getting mammograms. And if she does happen to get a mammogram, she has very dense breast tissue. So it can be harder to pick up something. Then the other factor is many times these women will go into their doctor and say, hey, I've got a lump. And they'll say, you're a young woman. You don't have to worry about it. You're only 26. Come back when you're 40. And those providers just haven't been educated to know that when a young Black woman comes in with a mass, we need to evaluate that and make sure that we're not missing a cancer.
Okay. All right. Mm-hmm. Yeah, that's it's very alarming to know that that's kind of how it's being handled. And it's true that I know some young people, young women in my circle and even younger who dealt with it. They are survivors, and it just makes you wonder why there isn't more awareness of it, and just why hasn't it become more of a part of the routine checkup. And but I think it's just doing things like this will bring that awareness up and hopefully motivate people to seek a second opinion when they're kind of told, well, don't worry about it, just to be sure.
Absolutely. And we'll talk about, because there are some national organizations that have come out and spoken on this. Okay. So let's talk about mammograms, because mammograms have been controversial. A couple of years ago, they told everybody, wait till age 50. And then when you get to age 50, get it every 2 years. And many of us who do this work every day said, no. The reason why we've done so well, the reason why we've decreased the mortality rate, why we have more survivors, is because of mammograms. Mammograms is the gold standard. It's the best way to image the breast, not perfect, but it is the best way to image breast. So what do we recommend? I always recommend that starting at age 35, if you don't have a family history, to get your baseline mammogram, just so we can take a look, see what's going on, and use that as sort of our baseline for what your breasts look like. If everything is good, then starting at age 40, then we should be getting mammograms every single year. And I always have to stress that, every single year. The purpose of the mammogram is that we can image it. If there's going to be something that comes up, we want to see it within that year, not 5 years later, 10 years later. And women will say, well, I've been getting my mammograms every year and something abnormal came up. That's what we want. That's what we use the mammogram for. We want to find that abnormality and have it be that stage 0 or that stage 1 breast cancer so that we can make a difference. Family history is key. We need to know who had breast cancer, and the age is key, because especially in African-American families, we tend to get not only breast cancer at younger ages, colon cancer, prostate cancer, many of the big cancers we tend to get at younger ages. Look at Chadwick Boseman, who had colon cancer at such a young age. So we've got to talk in our families. And if mom or grandma were 42 at diagnosis, just to give an example, those women should start 10 years earlier getting mammograms. So family history is important. I know some of our elders don't want to talk about it, but we need them to talk about it. We need to know that grandma had breast cancer. We need to know that great grandma had breast cancer and 5 of her sisters. This is the type of history we need to talk about. And what I always do is I always challenge people is when we're able to start doing family gatherings and cookouts, someone get some index cards and pass them around. And everybody write down what you had: high blood pressure, diabetes, colon, any type of cancer, any type of mental illness. Let's start documenting that. Somebody collect those cards and then pass that around so everybody knows, Uncle Joe had colon cancer at 35. That is important. We need to know that grandma had breast cancer at 41 so that the women in that family can start 10 years earlier getting mammograms. So very important that we've got to talk about this. We can't keep quiet. If we're going to save the generations, we can't keep quiet. We've got to talk in our families and talk about our health histories. So in screening women, the two of the large organizations, the American College of Radiology and the Society of Breast Imaging, realized that both Black and Jewish women are at higher risk for breast cancer, and especially at younger ages. So they came out a few years ago and said they recommend at least a risk assessment starting at age 30. So what this means is that all African American and Jewish women can go to a doctor, go to a breast specialist, go to a genetic counselor, and get a risk assessment where we're going to ask some questions, try and find out about that family history. And then if we deem necessary, we may start doing mammograms at the age of 30 in those women. So hopefully we can catch those cancers earlier. So this was something that came out about 2 years ago. And again, I think this is something we need to be screaming from the rooftops, letting every doctor know about this so that we can really start to catch these cancers at an earlier stage. So let's talk about mammograms. What do they look like? So this is the example of a digital mammogram. So on our left side, hopefully my left is your left, on our left side, that's a digital mammogram. And if you look real closely, you can see the shape of the breast. You can see the skin, very thin line. You can actually see the nipple on this. That's just how much clarity you get. And then the white stuff is what we call breast tissue or dense breast tissue. And that's just normal breast tissue. We're supposed to have dense breast tissue. As we start to get older, we're going to lose that density. But the density is what helps to keep us up and perky. And then as we start to get older, we lose that density, we lose the perkiness, and that's when the breasts start doing the downward sag. Happens to all of us, but in a good bra, we can help that out. And we'll talk about that a little bit later. And then on our right side, it just shows the old film mammography. So you can just see how just the technology, the digital technology has really improved, and we're able to find cancers. We're able to find 26% more cancers at an earlier rate with this new technology. And then maybe, and I hope everybody's heard about 3D mammograms. So a 3D mammogram is still a digital mammogram, but what it does, in addition to doing the views, usually when you go in for your mammogram, they're going to take 2 pictures of each breast. But in addition to that, the 3D mammogram is going to take pictures all the way through the breast. So if you look at the graphic here, you can see on our left, to show the 2D mammogram. That's just the standard mammogram. Just looks like some dense breast tissue, not much going on. But the 3D mammogram really peels away the layers, almost like turning the page of a book. So when we look at this on a screen, we can peel away the layers. And you can see here, as we move through these images, you start to see there's actually an abnormal lump there in the middle. And on image 43, you can see that's a lump there. We want to know what that is so we can get that checked out probably do a biopsy and make sure that's not a cancer. So 3D mammogram is the standard. If your doctor sends you for a mammogram, ask them for the 3D because it's the best technology that we have. Should be covered by your insurance companies, and you shouldn't have to pay an extra fee. We also can use ultrasound. So a mammogram uses x-rays, and it's just a low dose of x-rays. A sonogram or ultrasound uses sound waves, and that helps us to characterize the mass. Is it a cyst filled with fluid? Is it a solid mass? Is it a mass that has nice smooth borders? Is it a mass that has borders that are kind of jagged on the ends? And that will help us to decide whether we want to do a biopsy or not. And then we can use something called a breast MRI, and this just uses a magnet with a special contrast, and it looks at blood flow. So we can use the MRI sometimes to pick up teeny tiny cancers not even seen on a mammogram. But MRI is not for everybody because it is so sensitive. We only want to use it when we want to ask a particular question. So if we want to know what's the extent of this cancer, or this is a woman who has a very high risk, a lot of breast cancer in her family, so we're going to want to follow her closely with a breast MRI. And what I do want to mention is there's a program called the National Breast and Cervical Cancer Early Detection Program, or the NBCCEDP program. This is a program run by the CDC. This is a federal program. And what it does is it provides funding for all 50 states, including DC, the US territories, and 13 American Indian and Alaskan Native tribes. It provides coverage for screening. So patients who don't have any coverage can get a mammogram, they can get the diagnostic workup, and if they're diagnosed with cancer, they can get cancer treatment. So there should be no excuse in the United States of America that any woman should not be able to get treatment for breast cancer, should not be able to get a mammogram. It is covered under all 50 states. They all call them a different thing. I know we call it Project Wish in DC. I know many of the state health departments run them. So if you know of any women who are uninsured, underinsured, low income, they should not be sitting around wondering, can I get a mammogram? Can I get a pap smear? It is covered under this federal protection and this federal law. So it's really important for women to know that this is out there. And you could probably do a Google search if you go to the CDC website. They'll list each state and where you can get information on how to get enrolled in the program and be able to get a mammogram. So this is Breast Care for Washington. So this is a screening program that I co-founded in the Washington, D.C. area. And we're modeled on the same thing that the CDC is. We do mammograms for women, whether they have insurance or not. I just thought it was so important to be able to provide that access. We're located in a part of DC that has some of the highest mortality rates from breast cancer. So for the women in my community, they really have no excuse. They have a place where they can come, whether they have insurance, under insurance, or low insurance. And then we just recently hired a mammography van. So now we're taking it to the streets, taking it out to women where they need it the most. So let's start talking a little bit about breast cancer. How do we get to a diagnosis? Well, we can feel a lump and say, that feels suspicious. Or we can look at a mammogram or an ultrasound and say, that looks suspicious. But we really have to get a biopsy to make a diagnosis. And all a biopsy is we're just going to get a little sample of tissue so we can see, is this something non-cancerous or is it something cancerous? And the great thing about the biopsies, and I think it's important for women to know and not have any fear, is that 8 out of 10 biopsies that we do are going to be non-cancerous. So that's great. How do we do it? We can do it using a mammogram, which is called a stereotactic biopsy. We can use an ultrasound. And once you get in position, the procedure is the same. It takes probably about 15 minutes or so to do the biopsy. It's done using just local anesthesia. We just inject the area that we're going to be working with some local anesthesia, some xylocaine, lidocaine, same stuff the dentist uses. We make a little small incision. And this is kind of a graphic here. The needle goes in, we take out some pieces through the needle. And then after that, we put in a little small marker or a clip, because we want to mark the site. And then we wait usually about 48 to 72 hours, and we get the results, and we can tell the woman, no, ma'am, you're great. You don't have any cancer, or ma'am, you have cancer. Now we're going to get you into treatment. So this is a very simple process. It can be done by a surgeon, or it can be done by a radiology. Most mammography centers do them right there. You walk out same day, be able to go home and eat dinner and do whatever you normally do in your day. It does have some soreness associated with it. And we usually tell people to use an ice pack. So, but very simple, easy procedure. We can get the results quickly and figure out what we need to do. So when we talk about treatment, so the treatment options, surgery, radiation, chemotherapy, hormonal therapy, but something important to know is not everybody gets all of these things. We're really into personalized care. There may be some people who only get surgery. There may be some people who get only surgery and a hormone pill. There may be people who get surgery, radiation, and a hormone pill. So many different combinations, and not everybody has to get chemotherapy. And I know everybody's like, oh my God, chemotherapy. But, you know, chemotherapy is a great treatment when indicated. There's some tumors where you have to get chemotherapy. But the good thing about chemotherapy is they get their treatments on an outpatient basis. They're able to live their lives. They're able to just continue doing what they normally do. And then they just stop every 3 weeks to get their treatment. And then they keep moving along. So when we talk about surgery, you know, at one time, you know, everybody had to have the breast removed, but in this day and age, you don't necessarily have to, especially if it's a small area. So we can do what's called a lumpectomy, and that's where we're going to take the tumor out. We're going to leave the breast there. Then we'll check the lymph nodes, because if a cancer is going to spread, and they don't all spread, the cancer, if it's going to spread, will go to the lymph nodes first before it goes to any other part of the body. And then these patients who do lumpectomy usually have to get radiation. So just to show some live pictures, you can see in the top row sort of what we used to do after lumpectomy. And it's embarrassing to say we didn't do such a great job. We were really focused on get the cancer out, get the cancer out. But you can see the lady on the bottom, she actually had cancer surgery. But what we did, or whoever did this surgery, is did her surgery as a breast reduction. So when you look at her, she just looks like she had a breast reduction. You don't know that she actually had her cancer surgery. She probably had some droopy breasts, and so we were able to help her out. Here's one of my patients, that same thing. She had droopy breasts. She had a small cancer. You know, one of the things I asked her, I said, you know, have you always thought about a breast reduction? She's like, oh my God, yes, I've always wanted one. Was like, boom, guess what? You are going to get your breast reduction as part of your cancer surgery, which means it's covered by insurance. And if you look at her on the right side, she looks great. She was so happy, so excited. You can't really see where we did the cancer operation versus where we did the reduction. So lymph nodes, important. Again, if a cancer is going to spread, we're going to want to check the lymph nodes. In this day and age, we just take out, excuse me, a few lymph nodes. We can sample a few lymph nodes as opposed to taking out all the lymph nodes, which is what we used to do. When you take out more lymph nodes, you put women at risk for something called lymphedema. And lymphedema is where you get swelling in the arm, which is lifelong. You can treat it, but you never completely get rid of it. So we're just very careful about the number of lymph nodes that we take out in this day and age. So mastectomy is still a great operation. We still do it quite frequently, but there are different types that we can do. So mastectomy simply is just complete removal of the breast tissue. Some women choose one side, some women choose both sides. And you can see the young lady on the bottom, she chose not to have any reconstruction. What's also important for women to know is when we do a mastectomy, it's important to know that their risk of recurrence is not completely zero. It's about as low as we can get it, about 0.5% per year, which is pretty low. And then there's something called the Cancer Rights Act, which we'll talk about shortly. But you can see here on this slide, these are all the different types of mastectomies that we can do. We can do a skin sparing where we can save the skin. We can do a nipple sparing, and I'll show you what that looks like. Modified radical, we're going to take out some lymph nodes. We're starting to hear a lot more, especially than my younger patients who are doing bilateral mastectomies. They're saying, look, you know, I'm 35. I don't want to have to keep getting mammograms forever. So they may choose to get bilateral mastectomy. And then you have people like Angelina Jolie, who is a BRCA mutation carrier, and she had both breasts removed ahead of her getting her cancer diagnosis because she was going to get cancer. We just couldn't tell her at what age. So she went on and had her breasts removed, and that's what we call a prophylactic mastectomy. So this is something called a nipple sparing mastectomy. And if you thought these were two different women, they're not. It's the same woman. This is a young lady that I treated. She was in her 40s. She had a cancer on one side that we diagnosed. We did an MRI, picked up a small cancer on the opposite breast. So then she now has bilateral breast cancer. And she said, nope, that's it. Take them both. So she had what's called a nipple sparing mastectomy. So on our left is her native. You can see she had a little bit of droop. And you can see on the right is her after having the surgery. So she wanted to go a little bigger. She wanted to be a little bit lifted. And all of her incisions are under the fold of the breast. So, and those are her nipples. So this is what mastectomy can look like in this day and age, especially when we find your cancer early. Reconstruction. So the young lady on the picture before, she had breast reconstruction. We actually used, my plastic surgeon actually used implants. So implants can be made of either saline or silicone. It's the same implants that women use when they want to get breast augmentation. Or we can take tissue from another part of the body. We can take tissue from the belly, tissue from the back. There's some specialized centers who can take tissue from the buttocks. Tissue from the belly is nice because you get like a tummy tuck along with getting your new breasts, and women really like that. So here's a sample of a lady who, again, had bilateral mastectomy. You can see the markings on the left. We're going to take, I call it that little pooch that we all have below the belly button. It makes a great breast. You can see in the middle that's sort of after the tissue has been brought up to the breast. You can see her scar sits below the bikini line. And then you can see her final product where she had the nipples reconstructed, they tattooed in the color. So you can see with reconstruction, we really can get really great results. So let's talk a little bit about the Women's Health and Cancer Rights Act of 1998. This is a federal law that provides protection for breast cancer patients. And what this does, this says that insurance has to cover breast reconstruction. It also has to cover reconstruction on the opposite breast where there is not cancer. So that patient who I showed you that got the breast reduction, this is why she could get it, because it's covered under this law. It covers a breast prosthesis. It covers a pocketed mastectomy bra, and then also covers post-surgical bras and camisoles. So depending on the type of surgery that one has, they may need some post-surgical bras. They don't want to mess up their nice bras. So this stuff is covered by insurance with an order from your doctor. This applies to women whether they've had mastectomy or lumpectomy, and there's no lifetime limit. So if, you know, somebody had their mastectomy in, I don't know, 1990, they can come every year and get these items, new bras, and every other year get a prosthesis. And if you happen to pay out of pocket, you should be able to get reimbursed by insurance. So this is what bra prosthesis. So for a woman who chooses not to have reconstruction, or in some cases we may say, you know, it's just not safe to do reconstruction now, so we may need to delay it for 6 months to a year or even longer. And so they can get a bra. You can see on the lower left, it's a sample of a prosthesis and a pocketed bra. So the prosthesis just slides into the pocketed bra. And then there are two different types of prosthetics. There's a standard prosthesis, and on the lower right is something called a custom prosthesis, where really a woman can design her prosthesis the way she wants to. She can pick out her skin color, she can pick out the nipple, the areola size. She really can design it so it really matches her skin tone. And this is a picture kind of showing how the prosthesis, it fits right against the skin, goes right into the pocket. So when she goes out into the world, nobody knows that the breast is missing. And I love this custom prosthesis, especially for women of color. You know, I got really tired of places giving my patients pink prosthesis. Now, most of my patients are brown girls. what are they doing with a pink prosthesis? That just was ridiculous. And that was really what inspired me to open Cherry Blossom Intimates, because I really thought nobody was really paying attention to the needs of brown girls. Don't come up in here with no pink prosthesis, because that's not my skin tone. So I can get a brown one. I should be able to get a brown one, especially after I've gone through this experience that is so, can be traumatic for a lot of women. So again, all these items are covered under insurance. I'm going to keep moving. And now we're going to get into bra fit. So a lot of things that people don't know is that our bra size will change at least 6 times over our lifetime. And that's important to know, because I have women and I'll ask them, oh, when's the last time? Oh, I've been wearing this, 36 since I was in college. Yes.
Yes.
How about no? How about no? We all gained that freshman 15, and then we probably had some kids and breastfed, and we've gained and lost weight. Well, guess what? Our bra size is going to change with our body size. So what I tell women is, if you're changing the size of your jeans, you should change the size of your bra. So we should get fit for bras about every 6 months to 1 year. And it's a challenge to figure out what size, because there's no universal sizing. So we clearly need bras. They provide shape to our breasts, especially for those of us that get a little droopy through the years. It helps to create smooth lines through our clothes. And really, it helps to provide support to our back and neck. So here's a chart that shows bra sizing. And this is why bra sizing is so confusing, why you can't get it right. If you look at it, you first have to get the bra and figure out, well, who made the bra? Is it a US made bra? Is it a European made bra? Or is it a UK bra? And you can look, they all have different sizing. So American women just will not let go of the D's. We don't throw 5, 10 D's on it and still say we're doing something, versus the European and the UK women are like, look, once we get above a D, let's call it what it is. Let's go up to E, F, G, H, I, J, and on up. So American women, let's get out the D's. I can tell you one of the most common sizes is G. I sell more G-cup bras than any other size. So some of you women thinking you're a double D or triple D and it's not fitting you, you need to come on up to the G's. So what does proper bra fit look like, and why is it important? So if we look here on the left, you can see the before picture. She's looking a little droopy. But once you get her in the right bra, you lift that breast up from the belly. And guess what? She looks slimmer in that picture. It's the same woman. So a good fitting bra can actually make you look slimmer. So very important. It's helpful for your back. And you can get a really pretty bra no matter your breast size. So this is one of my pet peeves. I hate minimizers. I think they're awful. I think they should be taken off the market. And a lot of women who have larger breasts think, oh, I've got to minimize. Minimizing actually does nothing for you. And you can see here, if you lift the breast tissue up, it doesn't have to be up to your neck, but just a gentle lift up, your back is going to feel better, and you actually, again, are going to look slimmer. So again, I just always have to say, American ladies, we got to get out of the D's. You can see here on the left is the lovely Lyris cross. Lyris is actually a G cup. And you can see people think, oh my God, G cup is so big, but it is what it is. And she looks beautiful. And there's some beautiful selections. So just to touch on the Underwire and to wrap up, is that Underwire does not cause breast cancer. A lot of women hate them. If you hate your Underwire, that means you need a bra fitting. You need to get the right size bra, because it's probably cutting into you, and our wire should not be cutting into you. And for women who have implants, it is okay for them to wear Underwire. Just get an okay from your plastic surgeon. So all that really inspired me to open Cherry Blossom Intimates. We are a bra and intimates boutique and a mastectomy boutique. Located in Prince George's County, but we're also online. And I really wanted a place where women, whether you have small breasts, large breasts, if you're a breast cancer patient and you have one breast, no breasts, two breasts, that everybody could come into the same place and shop. And what's really fun is we get grandma who comes in with her daughter and granddaughter, and they all can shop in the same place. So we're an accredited mastectomy facility, and I have to update because now our bra sizes go from a double A through the letter O. So we have the letter O, and you can see our panty sizes go up to 5X. To me, it was just so important to be very size inclusive, not only inclusive to different skin tones, but to be size inclusive. No matter your size, we're going to find a way to fit you. So that Cherry Blossom Intimates were online, and Breast Care for Washington in the DC area. And with that, I'll say thank you and look forward to some questions and discussion.
All right. So first of all, thank you so much for all of that information. It was fascinating. It was enlightening. I learned some things. It confirmed some things. And, I think that if nothing else, women now realize that, yes, there's a lot to us. We have a lot to deal with. But more importantly, there are resources out there to help us as we, move through these situations or combat these situations, but also there's education that we can just, wrap our minds around so that we're fully aware of what's going on with our bodies at all times and, feel comfortable about asking the questions and getting the help that we need. So there is a question from Priscilla Fuller. She says, can the doctor also talk about symptoms of possible cancer besides the lump felt in the breast?
So the goal is not to have any symptoms. The goal is to just find something small on a mammogram. So I prefer that women don't come in with a lump. But there can be presentations like a bloody nipple discharge. There can be changes in the skin where it can look like somebody's kind of pulling in, like there's a little man kind of pulling and you've got some dimpling in. There can be fullness under the arm. So some women don't present necessarily with a mass in the breast, but they present with fullness and the lymph nodes are actually enlarged. And many times that can be our key to something being wrong. So, my goal is that with everybody getting their mammograms, we shouldn't be feeling lumps in the breast. If you do feel one, then I want the woman to find it before I can find it so that she comes in and says, hey, I feel this little pea-sized thing. I need to get this checked out.
Awesome. And we just want to remind our viewers, if you have any other questions, comments, or concerns, you can post your comments now in the thread, and we will ask Dr. Hampton to address your concern. Here's a question as well from Bonnie Edie. Thank you for watching, Bonnie, and thank you for watching, Priscilla, as well. What if no family members has had cancer, but you're the first one? That's an interesting question.
That's very common. So the two biggest risk factors for breast cancer are being a woman, ding, 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 and having breasts, ding, ding, ding. So in reality, as women, we all are at risk for breast cancer, and 1 in 8 of us will develop breast cancer. So what I would say is what we want to know is what's the age of the woman who has breast cancer, if she's the first one. Because depending on her age and the type of breast cancer, we may go ahead and get genetic testing and see, is there a mutation that we don't know about? And then we'll want to counsel the family members, because again, if she's a young woman under the age of 50, we're going to want to be more proactive in those family members and trying to get them. They may need to go into screening a little bit earlier. They may need to just get a breast exam so that we can find out what's going on. But being the first, sometimes I know it can be challenging, but, I think with, a good team, a good breast cancer team, you can get through it and be a survivor.
All right. Well, we're going to take a break and allow Dr. Hampton to just kind of catch her breath a minute. And so, we'll do a couple of little commercials and then we'll be right back. We've got some important announcements and we're going to finish this discussion. And once again, if you have any comments or questions, please post them and we'll get right to them as soon as possible. So just give us a minute. We'll be right back.
If you want to support Black-owned and operated businesses in the Grand Strand area and beyond, check out the networkconnects.com for a complete list of establishments in our local area. Our network connects Black businesses to community for a wide range of services, products, organizations, and resources that are viable in the African American community. You'll find a wide range of products and services that'll fit your needs, along with information about events and happenings around the local communities. Check out thenetworkconnects.com, connecting Black businesses to community. Thenetworkconnects.com.
For all of your insurance needs, home, auto, and life, see how it feels to be on a #1 team with Tony McAfee of State Farm Insurance. Call Tony at 843-903-7800 or visit him at 3888 Renee Drive in Myrtle Beach. Like a good neighbor, State Farm is there. Looking to start a new career? Train to work in Myrtle Beach. Classes starting soon. Free to eligible participants. Short-term, 3 weeks or less in hospitality, culinary, electrical, plumbing, and more at Horry Georgetown Technical College. There's more. Continuing education at 843-477-2020. Horry Georgetown Technical College, where there's more. Enjoy soul food the way your mama made it. You'll be surrounded by some of the best food in Horry County and affordable prices. Blue plate specials, senior plates, and more. Daily specials at Big Mike's Soul Food. Big Mike's Soul Food is located at 504 16th Avenue in Myrtle Beach. You can call your order in at 843-712-2048 or visit BigMikeSoulFood.net to find out about the latest specials. Big Mike's Soul Food. Soul food, the way your mama made it. Treating conditions from A to Z. Schedule an appointment today. Ask about acceptable insurance coverage at Waccamaw Primary Care, 660 Singleton Ridge Road, Conway, South Carolina. Dr. Winston D. McIver Jr., a trusted and reputable source in Horry County and beyond, has all you need for family practice and sports medicine. Call 843-234-4362 to schedule your appointment today. Waccamaw Primary Care, 660 Singleton Ridge Road, Suite A, Conway, South Carolina. 843-234-4362.
Family owned and operated since 2001, a veteran owned company. We're your #1 property cleaning company serving Horry County and surrounding areas. Superior Window Cleaning has all that you need for residential and commercial property cleaning. Mention WCM Live and receive free window cleaning with power washing for up to 15 windows or free power washing for up to 200 square feet, flat work only with any window cleaning job. Call 843-889-7255. That's 843-889-7255.
And we're back. And again, we have special guest Dr. Regina Hampton with us today to talk about breast health and the importance of screenings. Sister Joella, what are your thoughts?
Ma'am. Oh,
Yeah, what are your
I'm
thoughts?
just drinking in all of this knowledge, and I think that we should continue to carry on this important topic because Dr. Hampton has already told us how we need to educate our young women in the community to get them to start thinking about having a mammogram just because, something is happening and we don't know why. They're getting younger and younger. So again, this is what I wanted to, just elaborate on. And the other thing, Dr. Hampton, I wanted to find out about, do you get any male patients with breast cancer?
Yes. So male breast cancer accounts for only about 1% of all breast cancers that we treat. One of the good things is usually a man is going to find a lump a little quicker just because they have less breast tissue. But their treatments can be the same. They can get a lumpectomy, they can get a mastectomy, they can get the same hormonal therapy as well if indicated.
Wonderful. Yeah. We need to educate the young males as well. We don't know what's happening with them. So again, everyone needs to be educated. That's important.
Right.
Thank you.
And it definitely is important because I'm sure that when it comes down to men thinking about breast health, there's probably a little ego, little pride thing there, not really, wanting to go in and talk about those types of issues. But, having that conversation with your doctor can save your life. And so, that's definitely something that probably needs to become more of an initiative in our communities. And, maybe it will start with, some of our male doctors as well, or, some organizations that support young men and their development to actually have that conversation and, create some seriousness around it.
Yeah. Well, and I think, you know, in the African-American community, we've got to stop being afraid of words, because I have patients say, well, I'm not going to say the C word. Don't say the C word. And what I do is I purposely get my patients to say it. They're like, well, I'm not going to say it. You know, I've been doing this work for 15 years. I probably say cancer just about every day in the last 15 years. But I've also spoke $1 million. I haven't had that happen either. So people are like, speaking of, well, where $1 million at? Where is that?
Oh, God.
So I'm all about, we speak it into an existence, but
That's
you know,
right.
we really need to have the cancer conversation in our families, and especially in African-American communities, because not only with breast cancer, again, colon cancer, prostate cancer, you name it, we tend to get these cancers at younger ages. So we need to say the word so that we can educate our community and we can get people to come in, see their doctors and get something checked out and not wait until it's too late.
Exactly. Our viewer, Bonnie Edie, she says, and, you know, a lot of people are in denial about, and that's true, you know, so how do we remove the stigmas and, you know, all these preconceived notions about things and just, you know, make sure we're taking care of ourselves, even in ways that might feel embarrassing.
Right. I think the big thing to know is that, you know, things have come a long way. And, you know, I often just say to my patients, look, you know, I know your mother was treated 20 years ago, but we're not doing that same treatment that we did for her 20 years ago. We're doing things, your cancer is going to be a different cancer. The treatments are just better tolerated. You may not even need an aggressive treatment. So it's really just trying to let go of some of the old stuff. Yes, chemotherapy was bad back in the day. Yes, surgery was bad back in the day. But, you know, in modern medicine, we're just able to do a lot better. We know a lot more. The other thing I think we as African Americans have to consider doing is getting involved in clinical trials. So, you know, we often complain about, well, the medicines don't work for us, but we've got to get in the clinical trials. Many times we have just different genetic makeup, different physical makeup. And they've shown this in high blood pressure medicines, that there are just some high blood pressure medicines that work better in African American patients. Well, we might be able to find that information out as far as cancer treatment, but we've got to be in those trials to know the answer. And I know we're kind of going through this thing now with the vaccine, and there's a lot of mistrust in the community, but we have to realize and look at where we came from and realize that, unfortunately, yes, there were some things that happened, but the medical community has changed how they operate because of some of those things. They were called out for them. And because of some of those things, we're doing better. We're being held to the fire. And so we have to sometimes let go some of those things and be informed about what's going on today.
All right. Dr. Hampton, I've seen reports, read some articles, don't know how valid they are, about this thing called COVID breast. Is there any validity to that, since there are a lot of there's a lot of anxiety surrounding COVID, and of course, like you said, now the vaccine. So can you shed any light on that?
So there's not a COVID breast, thankfully. But what they're recommending is that if you're going to get a mammogram, that you should wait about 4 weeks. So if you get the vaccine, you should wait 4 weeks before you get your mammogram. And the reason for that is because on the side that you get the vaccine, sometimes the lymph nodes can get a little enlarged, and that's just what we want the body to do. We want the lymph nodes to get enlarged so that if we're ever exposed to COVID, then we know how to, our body knows how to handle it. That's really the only treatment. You know, we still do surgery if somebody's had the vaccine, but definitely if you get the vaccine, you may want to just wait a little longer before you get that mammogram, unless you have something in your breast that really needs to be checked out. Then don't wait that 4 weeks. Come on in so we can get it checked out.
Well, thanks for clearing that up, because I read an article and I was like, really? There's got to be more to it than this, So,
yes.
Yeah, I appreciate that. Okay. All right. Well, we have almost covered an hour of on this topic, and certainly the information is invaluable. We can't even put a price on what you shared with us today. The price is your life, really. And if you take the time to share this information. You can share this video with your loved ones and have conversations about it and come up with, plans of care or questions for your own doctor. We have to thank Dr. Hampton for giving us this wealth of knowledge today. It was certainly wonderful, useful, beneficial information, not only for the women in our community, but for our entire community, because we covered, a couple of different things. And I know I appreciate you being here today, and I know Sister Joella does.
Oh, yes, yes. And I just have a couple of things to say after she has finished.
Yes.
After she has finished giving the last words, if you will, because I just wanted to thank everyone. So, Doc,
yes,
you
ma'am.
have the last words to say to us?
Yes, and then we'll let you go. Yeah.
I don't have much more to say except, just encouraging women to get their mammograms, encouraging women to just understand their bodies and don't be afraid if you notice something that feels different. It doesn't always have to be something cancerous, but we've got to talk in our families. Let's talk about our health histories in our families and really try and make a difference.
Okay, awesome. Well, once again, thank you so much for being with us this evening. We, can't thank you enough. And, hopefully we can have you back at some point later on to talk about other issues or things that we really need to educate the communities on. But until then, God bless. And we really do appreciate having you here today.
Just want to say one thing. Just want to say a couple of things and just thank God for this beautiful, powerful forum tonight, what we've discussed. I thank you, Sister April, and my husband for allowing me to be able to just come on and just share that with our community. I would like to thank Sister Sonia, the beautiful mother of Sister Dr. Regina, for the love for the community that they have. I know where wards 7 and 8 are located in Washington, and that's an area where our people are neglected. So again, thank you for being there. And this show was dedicated to all of the survivors of breast cancer and remembering the ones who lost the battle of breast cancer. And I would like to close out with I had a sister who just lost her mother, Sister Catherine. So may we bless her family. God bless her family. And the last thing is, because we're talking about women, we have to remember a powerful woman who paved the way. All of the programs that you were talking about, fighting to get insurance and everything. This mother fought back in the 50s and the 60s. Mother Fannie Lou Hamer. And on yesterday was the 44th anniversary of her death. And it wasn't as a result of what happened during the struggle, how she was beaten, but it was because of breast cancer. And if she had a Dr. Regina Hampton with her at that time, maybe things would have been much better. But this is also a tribute to her and for us to keep fighting for all of the things that we need to make our communities a better place to live. God bless you and thank you. And we go off with what Sister Fannie Lou Hamer said. Okay, thank you.
Awesome. Before we, Dr. Hampton, you can feel free to stick around, or if you want, you can definitely go and get some rest at this point. We're going to do a couple of community announcements and then we'll roll this clip. But certainly you're welcome to just stick around. We definitely want to make mention of a few things before we actually roll this, the piece on Miss Fannie Lou Hamer. One of the things that, of course, we're working on as an initiative in the community is the UNCF scholarship drive. And so we do have donations rolling in. We've got a lot of support from everyone in the community. And on behalf of the local committee, which is being led by Marjorie McIver, and the area development director out of Atlanta, Rosalind McGinnis, thank you all for your donations that have come in. If you want to continue to give, you can go to uncf.org/PDMMB. And if you go to that website, you'll be able to see a lot of great information about what's happening with the scholarship drive. And particularly, there is an upcoming Mayor's Mass Ball. And just wanted to make sure that everyone, sees the website so that you'll know what's going on. But this is where you can get all of the great information about the Mayor's Mass Ball. And you can donate, get tickets. The ball is happening it's virtual, as a matter of fact, happening March 20th from 6:30 to 9 p.m. If you have any information, or if you need any information, you can contact Rosalind McGinnis to get more info about the actual mass ball. But there's a place where you can donate. There's a place where you can get tickets, and the ticket is like an electronic access to the actual virtual venue. So it's not a paper ticket or anything like that. But once you've made your donation or you want to purchase tickets, she will make them available for you. And of course, for the lineup, there's information on that website about who is going to be present for that event. It's being hosted by Kim Coles, actress, author, and comedian. She's the mistress of ceremonies for the local event. And then honorees are also from the local area. And for the national event, special guest appearances by Samuel L. Jackson, Chaka Khan, and Stephanie Mills. So we wanted to make sure that everyone is aware of the mass ball that's coming up. And if you give your donation by March 18th, you will be recognized as one of the donors for the UNCF Scholarship Drive. So definitely wanted to share that information with you so that everyone will know, what's coming up with that. Also, we have the Whittemore Alumni Scholarship, which deadlines on April the 30th. We had Tanya Pickett on the network live on Friday, and she gave some great information about how you can get the actual application and, the criteria. So we'll repost that show, but also, if you want more information, just please let us know. Talk to your young people, help them with the scholarship application. And of course, we're also looking for donors for that alumni scholarship drive. So again, but we want to make sure that we have applicants who can take advantage and benefit from these donations. So the Whittemore Alumni Scholarship application deadlines on April the 30th. It was extended because of COVID. And we'll be posting more information to the World Community Magazine's page so that you can find out how to apply, but also how to donate as well. There's a couple of other things that I wanted to mention. The Conway High School class of 1971 is putting together a class reunion. And so they're in the process of trying to identify all of the students, classmates who were in the 1971 graduating class. And if you don't know, this year commemorates the 50th anniversary since the first senior class graduated at the integrated school now known as Conway High School. And that was in 1971. So to celebrate the occasion, the class of 1971 is planning an event for May 22nd. And it's from noon to 3 p.m. This will be an outdoor event held in Conway with all the necessary safety protocols in place. But the location is to be determined. They just need to get the information out, but also to find classmates, so identify classmates. So if you can help with that and distributing the information, please contact Priscilla Wyman Fuller. And here's her email address and phone number, but also Valerie Skipper, and here's her phone number as well. And they really would appreciate any help that you can give. So that's what I have tonight, Sister Joella, as far as announcements are concerned. And my dog's barking in the background. I'm sorry.
And thank our viewers and listeners tonight. God bless. Okay.
All right. And thank you so much, Dr. Hampton. We're going to learn a little bit about Miss Hamer.
Okay.
In Mississippi. That was the purpose of the Freedom Summer Project in 1964.
In Atlantic City, the Freedom Democrats hope to be seated at the National Convention nominating the Democratic presidential candidate. Their first step was to present their case to the Credentials Committee. Fannie Lou Hamer testified on their behalf. The national broadcasting networks carried her words.
And if the Freedom Democratic Party is not seated now, I question America. Is this America, the land of the free and the home of the brave, where we have to sleep with our telephones off of the hook because our lives be threatened daily, because we want to live as decent human beings in America? Thank you.